Okay, so we're going to talk about Paget's disease, a condition which in my career, when I started out in the latter 70s, early 80s as a fellow, was actually quite a common problem. Today, there's a lot less of it, except in Italy, where they claim it's still quite common. Why it's less common may be obvious, at least we can speculate why it's less common, but as I talk about etiology, but it's still a condition you should know something about, because as endocrinologists, if you do clinical work, not necessarily as a pediatrician, pediatric endo, but if you do clinical work, there's a reasonable chance you will see Paget's disease. It'll be milder than it was in an earlier era, but the treatment is the same, and you can do an awful lot to help people with this condition, so it's worth knowing something about it. Sir James Paget described the condition. He was a surgeon and a pathologist. He was one of Queen Victoria's personal physicians, and he described the first cases of it in 1876 in a journal in the UK. The UK was a place where there was a fair amount of Paget's disease. Clearly, this was an era before they had radiology. There were no Xrays, but you could look at people and see certain characteristic changes. And Paget wrote in a very wonderful first paper that the disease begins in middle age or later, which is true, affects most frequently the long bones of the lower extremities and the skull, which is true. He obviously couldn't see the pelvis because that's a little harder to appreciate on physical as having pagetic change, but he could see the alterations in the skull and in the lower extremities. And he pointed out that the bones enlarge and soften. Now, soften is a tricky word, but those bearing weight yield and become unnaturally curved and misshapen. And he's right. I mean, all of that is clearly true. Paget's disease is not really a metabolic bone disease. It is a localized disorder where in the bones that are affected, the initial event is an increase in bone resorption, secondarily followed by an increase in bone accretion. The result of this rapid, high turnover, localized disorder is a denser, structurally inferior bone, which is prone to deformity and fracture, deformity much more commonly than fracture. And this was the illustration for his first case. This guy has really bad polyostotic Paget's disease. Paget's disease is either going to affect a single bone, in which case it's called monostotic, or more than one bone, in which case it's called polyostotic. And as Paget pointed out, the bones enlarge, and this guy's skull was big, and this shows his hat size as a younger man and his hat size as an older man. He has involvement of numerous bones, and he has some of the complications associated with having deforming bone disease. He's walking with a cane, and that could be for one of several reasons. One possibility is that in the setting of the bowing deformities that he's got, this is a bowed femur and a bowed tibia. There's sort of anterolateral bowing, and it's more striking on the left than on the right, although you may have had involvement on the right. If you have a bowed extremity, it gets shorter. If you think about a bow from a bow and arrow, if you take the bow before you put the string on, and then you put the string on, it gets shorter. So he may have been walking with a cane because he was limping. It's also entirely possible, and this is actually very important, this curvature may have set up problems at the joint spaces, where the curved bone doesn't fit as well in the joint space, and the bone gets enlarged and deformed, so that you can get a secondary osteoarthritis, and especially in an older individual, you may have some underlying osteoarthritis, and it's only made worse by the deformity at the joint spaces. So he may be limping in part because the leg is shorter. He may be limping in part because he's got an osteoarthritis at the joints. The other possibility is that he's got back troubles. You can appreciate there's a little bit of a curve to his back. I don't know if he had involvement of pagetic vertebrae, but you can get spinal stenosis in the lumbar spine because the bones are bigger. They take up more space, and the nerve roots are more likely to be impinged upon. So he may have had spinal stenosis, which was the source of his limping. Hard to say. Whether he had pelvis involvement or not, we don't know, but I wouldn't be surprised. And again, that could impact the hip joints quite substantially. The other thing about this guy that is utterly fascinating is that he died of an osteosarcoma. And osteosarcoma is an extremely rare complication of Paget's disease. We'll talk a little bit more later about both osteosarcomas and giant cell tumors in Pagets. Let me say right now that one of the big distinctions between these two neoplastic changes is that giant cell tumors are benign. Osteosarcomas in these elderly Pagets patients are almost uniformly fatal. It's very difficult to survive, unlike children with osteosarcomas where we can do a great deal. So the fascinating thing was he had one, and as I said, they're quite rare in Paget's disease. Nobody really knows the true incidence. It's supposed to be less than 1%, whatever that means. But it may well be that now that we have fewer people with Paget's, what just happened? We have fewer people with Paget's disease, we think. There may be less in the way of osteosarcoma, but we don't really know. Giant cell tumors are benign, and they can be remarkably well managed with episodic courses of dexamethasone. They shrink right away, although all that dexamethasone is not the best thing in the world for people. We'll come back to that. So why does Paget's disease happen? Well, this is a bone biopsy from a patient that we studied many, many years ago. And this is, of course, the mineralized bone. What you see here is an osteoclast, and the osteoclasts in the affected skeletal sites are greater in number, they're way too big, and they can have 50 to 100 nuclei per cell. The ordinary osteoclast may have, 5, 10 nuclei per cell. It's a multinucleated giant cell in essence. But the pagetic osteoclast is probably the result of fusion of osteoclast precursors that come together and form these gigantic osteoclasts at affected skeletal sites. And what happens is, because you have more of them, and they're so big, you get a tremendous amount, or not necessarily a tremendous amount, but you get a substantial increase in bone resorption, and then the osteoblasts move in and try to correct this. So this is another very old slide. This is the mineralized bone here. The marrow, when you have a high turnover state like this, becomes somewhat fibrotic. If you ever have to do a bone marrow aspirate on somebody with Pagets of the pelvis, it's quite a challenge because the marrow becomes fibrotic. And the bone is very thick. It's very hard to work with. But this is fibrotic marrow. This is a blood vessel, and when you have this very high turnover state in Paget's disease, you get a marked increase in vascularity, which means that if somebody's got a pagetic tibia, where there's not, you don't have a lot of muscle, you mostly have skin over a lying bone, and you put your hand on the tibia, or you put your hand on the face if somebody's got Pagets of the skull, you feel an increased warmth from the increased blood flow. Now this is true when it's active Pagets. If you treat somebody with a bisphosphonate and you shut down this high turnover state, which is the way we manage the condition, the heat, the vascularity shrinks and the heat goes away. So what you've got here are osteoclasts, too many of them. They're way too big, where you see not doing this very well. This is a resorption cavity where you had osteoclastic bone resorption. And up here you have sort of a freight train of osteoblasts that are moving in as fast as they can to lay down new bone. And the problem is the whole process is so speeded up, at least that's what we think is going on, that the quality of that new bone is very disorganized. So instead of laying down sort of nice lamellar bone, the new bone formation, which is constantly happening, is happening in a much more helter-skelter manner, and you get very disorganized looking bones. So this is a famous slide of scanning EM of normal trabecular bone. You're very familiar with that. At the same magnification, this is what the bone looks like in the person whose cells I just showed you, and you can see that there's a complete loss of the normal architecture, and what you've got is just this thickened mess. This looks like somebody took an ice pick to the bone, and that's actually due to the tremendous localized bone resorption. I mean, it's really quite a dramatic image. So that's what's going on. Now, almost any bone can be affected, but there are sites that are a lot more common and sites that are less common. Very common sites of Paget's, if you were just going to do a skeletal survey, if you didn't want to do a bone scan, we'll talk about that later as well. The bones that are most commonly affected include the pelvis, and in many cases it's not the whole pelvis, it's a part of the pelvis, the sacrum, the femur, the tibia, the skull, and vertebrae. But you can certainly see it in the scapula, the humerus, the clavicle. You can see it in a single patella. You can see it in the forearm. You can see it in the heel. You can occasionally see it in ribs. It's relatively uncommon to see it in the fibula. I think the mandible is not as uncommon as they say on this slide. And you rarely see it in fingers or toes, but I have. I mean, if you see enough patients over the years, you occasionally do. So the big bones are the ones that you care about, the ones that are listed under common. The epidemiology is evolving. There's a high prevalence in the UK, Australia, and New Zealand, where people come from the UK. And certainly in the United States, we see people whose origins are Western Europe. There's a very, very low prevalence in Scandinavia and in places like China, Japan, and India. You occasionally see a patient. About 20 years ago, I made my one and only trip to China, and when I was in Beijing, they brought in to allow me to visit with, because this was 20 years ago and we saw a lot more Pagets. There's apparently a lady who lives in China who is Chinese. She doesn't have British ancestry because there's a lot of it in Britain. And she had classic Paget's disease. And whenever an American with an interest in Paget's disease would show up, they would bring this lady into the hospital so that she could meet that person. You know, the UK is the place where it was first described. We certainly see it in Western Europe. We see it in Eastern Europe too. There's not a lot of good epidemiological data about it, but we certainly see people in Eastern Europe who have it. In many parts of the world, the incidence is decreasing. And if there is, and I will show you evidence to suggest there is a genetic aspect of this disease, it may well have to do, at least in the United States, and also perhaps in Australia and New Zealand, with the fact that populations are not as genetically homogeneous as they were. Back in the 70s, if I saw an Italian-American patient with Pagets, and we had a lot of Italian-Americans with Pagets, mainly because in the New York area there are a lot of Italian-Americans. And if I saw an Italian-American patient who back in 1979 was 78 years old, that patient's parents were both Italian, and that patient's 4 grandparents were Italian, and very likely they were not only Italian, but they were from the same part of Italy. Today, if you bump into somebody who has an Italian last name, that person may have a German grandmother and a Swedish grandfather. So there's been a considerable change in people's genetic inheritance, and maybe that's playing a role, because we are clearly seeing less of it, except the Italians in Italy claim they still see a lot of Paget's disease. So there may be something going on with that. But certainly in the New York area, the bulk of the patients I used to see were either Italian-American or were Jewish or were from other Western European or Eastern European ancestry. And we just see far fewer people today. We've seen people from South America. They certainly have it in South America. We see people from a number of parts of the world, but this is what we know. The prevalence in men and women is nearly equal, but it's thought to be a slightly higher prevalence in men than in women. And a family history is not rare. We say positive in as many as 40% of patients, based upon 1 or 2 studies which found a family history in 40% of patients. It may be a higher number, I don't know, but that's what usually gets cited in the literature. Now, this slide is sort of interesting for a couple of reasons. One is that this slide was made in about 1978. And in 1978, boy, it is a long time ago. God, I'm getting old. It was possible that the etiology had to do with some undescribed genetic factor, but there was also evidence for some effect of a slow virus infection of bone. And I would argue that we've refined both of these a lot, but we're still not 100% sure what the etiology is. So let's talk a little bit about the genetic aspect of it. We knew about the family history being positive, and large families with Paget's disease in multiple generations have been reported. So it used to be said that it was an autosomal dominant type inheritance, and maybe that's still true. If you have a pretty good sense that, if somebody says they have familial Pagets because they really know it's true, you can believe them. If they say they don't know of a family member, you're never quite sure if that's because they didn't know or if it really was a so-called sporadic case. But in the clusters of familial patients, there's probably, for a member of such a family, a 7 to 10-fold increased risk of developing Pagets if you have a first-degree relative with Pagets than if you don't. It may well be that familial cases have an earlier age at onset. We believe that the familial cases are more likely to be polyostotic and more likely to have bone deformity. In other words, there's a more severe phenotype when you have a familial rather than a sporadic form of Paget's disease. At least that's what was the case when we had lots of people that we were seeing. As I said before, the osteoclast is the cell that seems to be the predominant troublemaker. They're increased in number and size, increased number of nuclei per cell, increased bone resorbing capacity, and it was apparent even in the late 60s that when you looked at the nuclei and also the cytoplasm of pagetic osteoclasts, you could see what looked like measles virus-like nucleocapsid inclusions. Now, Paget's is not the only condition to have viral-like particles noted, but this is pretty classic. Pagetic osteoclasts will have these inclusion bodies. And when we say measles virus-like, for a long time it was thought to be either measles or respiratory syncytial. I think measles is the one that they focus on today. And what's interesting is that this type of paramyxovirus is capable of causing cell fusion. So it's not surprising. Measles was very common for a very, very long time. It was very unusual to see anybody back in the 80s who didn't have a childhood history of measles, but once measles vaccination came along, we stopped seeing measles. And I think as a consequence, maybe that's the other part of the reason why we're seeing less Paget's disease in countries that have active vaccination programs. So this disease may disappear entirely someday. The osteoclasts, as I said, contain paramyxoviral-like nuclear and cytoplasmic inclusions, and measles virus nucleocapsid proteins and transcripts are expressed in osteoclasts. And this isn't even new. This is old stuff, just supporting the idea that there may be a viral etiology. In terms of the genetics, there have been many, many gene mutations that have been described, predominantly involving something called sequestosome 1, encoding for the P62 protein, which is a scaffold protein that plays a role in rank ligand signaling in osteoclasts. Don't ask me any questions about this because this is way out of my pay grade in terms of fully understanding it. P62 is mutated in 25 to 30% of patients with familial Pagets, but not as much in sporadic Pagets. And there have been numerous P62 mutations. If you read the genetics journals, they're constantly coming up with some new sequestosome 1 abnormality that may play a role. And I'm not even sure this is the whole story. A paper from Cell Metabolism in 2011, which I found fascinating. You can write this down, but there's no way they're ever going to ask you questions about this on boards. I mean, they're not going to get into this. The clinical stuff, maybe. Data from 2011 suggested that measles virus nucleocapsid protein alone can cause Paget's disease, but the susceptibility to Paget's and the severity may be influenced by the gene mutation. So it's probably a double hit phenomenon. Sequestosome 1 mutations sensitize the osteoclast precursors to the stimulation of rank ligand, and the measles virus part is responsible for the characteristics of osteoclasts, their behavior in Paget's, increased number, increased nuclei, increased bone resorption, etc. So this, I think, was a very important paper trying to explain why these two components from my 1976 slide are still true, that there's some combination of genetic predisposition and probably measles virus. That you probably should know, but the details I don't think you have to worry too much about. Let's talk about it clinically. So what's so fascinating about Paget's disease is the many, many different ways it can present. Many patients who have monostotic Paget's never know they have it, never have symptoms from it, and it's noted that the majority of patients it's going to be an asymptomatic finding. But sometimes, even though it's asymptomatic, when you incidentally pick it up, you still may want to worry about what progression of such an asymptomatic lesion might do, and you have to think a little bit about that. But when you do see symptoms, there are a number of different categories. The musculoskeletal complications of this enlarging, deforming bone disease are skeletal pain, which can be the result of just the bone itself, little microfractures, just, the increased vascularity, whatever. There can be a sense of discomfort. Skeletal deformities are very obvious on physical exam. I think we still do physical exams occasionally on people. You will sometimes see a fracture in pagetic bone, or you will see a partial fracture. I'm going to show you a bunch of X-rays. The secondary osteoarthritis is the real deal. And one of the tricks is when somebody has pain radiating down the thigh, and the patient has a pagetic femur, and the patient has spinal stenosis from non-pagetic degenerative joint disease, it can sometimes be a little bit difficult to figure out whether their discomfort is from a pagetic site or is referred from a non-pagetic site. And sometimes we treat the Pagets not even convinced we're going to take care of the symptoms, because the symptoms may not be from the Pagets, but you do it anyway, because if you've got bad Pagets in a femur, even though that may not be bothering the person, the deformity may get worse over many years, so maybe you shut the thing down. But it can be very tricky to sort out what you think is coming from what. So this is an X-ray of a femur, and the important thing on this X-ray, and this is the kind of thing you may see on a board exam, is that this is the first phase of Pagets is an osteolytic phase. Before it scleroses over, you get this osteolytic phase, and this is sometimes called a blade of grass lesion or an osteolytic wedge, where there's osteoclastic resorption and the coupled new bone formation hasn't quite caught up yet. So it usually would start at the end of a long bone, and it may extend over many years higher and higher, making the bone, the new bone formation that follows the lysis, the new bone formation throws the bone down in a haphazard way, so the bone doesn't have the good architecture that it should, and that's when you may see a bowing deformity over time. This is an example of a pelvis X-ray, and you can appreciate that there's a difference between the non-affected left hemipelvis and the affected right hemipelvis. And what you've got here is a greater sort of whiteness. It's more dense than it is on the other side. This line is called the ilial-ischial line by the radiologists. Here, it's quite discrete and thin, very clear borders. And here it is thickened and it's sort of rougher looking. This bone may be slightly bigger than its equivalent side on the other side. The hip joint is well preserved, but over time, if this continues to sclerose and thicken, you could imagine that it would have a negative impact. This guy was only in his early 40s, and it was picked up incidentally because he was getting a checkup and his alkaline phosphatase was noted to be elevated, so they started working up his liver. His liver was negative, so then they decided to work up his bones, and on bone scan this lit up in the hemipelvis, and they said, then they took an X-ray, and they found Paget's disease. I remember this guy vividly because he was a DEA agent, and when he came to see me, his first question when I asked him to please step into the room where he could take his trousers off, he said, "What should I do with my gun?" And I said, "Your gun?" He said, "Well, I'm a DEA agent." So I suggested he put it very carefully on the windowsill and keep it as far away from me as humanly possible. It was terrible. Anyway, so this is somebody with a lot worse Paget's disease, and I don't know that you're going to see X-rays like this very often, but you can see the completely disorganized architecture. You'll notice that in the femurs, you've got marked cortical thickening. The bones are bigger. He's got involvement everywhere. It's harder to see where the hip joint's sort of tight right there, sort of sclerosed over right there. So this is really, really bad news, Paget's, which may or may not be very symptomatic, but it's a fairly classic example of what, in the old days we used to see. I'm not sure how often you would see this today, probably not very. This is an example of one of the complications at the hip. Again, it's a hemipelvis that has Paget's, and the other hemipelvis does not. But this is called protrusio acetabuli. If you were an orthopedist or a rheumatologist, you would call it. It sort of bulges out. It's softer, and everything just sort of gets all tight and messed up. You can operate on these hips and replace them. You would ideally, if this were you would want somebody who'd done it before in a patient with Paget's disease. And we would argue that if you have active Paget's, by active I mean the alk phos is significantly elevated. I mean, if it's 120 or 137 with an upper limit of 100, I'm not sure I'd get too worked up. But if it's 300, 400, you want them to pre-treat before you do elective surgery because of the worry about blood loss, because this is very vascular bone when there is high turnover. So you'd give a shot of IV zoledronic acid, and you'd wait a few weeks, and then you could probably do the surgery. The poor patient, of course, if the patient is bisphosphonate naive, the shot of IV zoledronic acid is going to make the person pretty sick the next day with what feels like the flu. And it's crucial that we warn people that they're going to feel that there's about an 80% chance they're going to feel awful the next day with their first ever dose. usually a year later should you need to repeat it, or as you know in osteoporosis, when you give a second dose a year later, there's no reaction at all. And you can blunt the acute phase reaction by giving Tylenol or Motrin or whatever the patient wants to take. I usually tell them when they go home from the infusion, they're going to feel fine, and I say, when you go to bed tonight, take a couple of Tylenol, and then tomorrow when you get up, take some Tylenol or some Motrin, because if you can blunt the fever, you may not feel quite as sick. It's an acute phase reaction. Gamma delta T cells explode after you give the first ever dose. And as I said, if you warn the patient, they will feel lousy, but at least you warn them that it's harmless, it's not the flu, and that they're going to be better in 24 to 36 hours. So. This is just an example of involvement of the vertebrae, and I'm not sure I can. This is probably a non-pagetic vertebra. Down here, you see the trabecular markings are much coarser. So a good radiologist can look at something like this and say, oh, this is bigger, and it's a little teeny bit deformed, and the trabecular markings are greater. Maybe there's a little bit of cortical thickening in these vertebrae. So you should be able to make a diagnosis of involvement of the vertebral body. Now here's the pearl. Hemangiomas can also make the vertebral body look dense. Metastatic disease to a vertebral body can make it look like an ivory vertebra, but the posterior elements are usually also pagetic in Paget's disease. So if you've got a pagetic vertebra, not only is the vertebral body going to look pagetic, but the posterior elements are going to look pagetic. And on a bone scan, you can appreciate that this will light up as well as this, whereas usually in Mets or in hemangioma, it's just the vertebral body. I mean, you ought to be able to distinguish one from the other. You can always do a biopsy when you're not sure, but you really don't want to do biopsies, because if you biopsy a hot pagetic bone, you may crack it, break it. I mean, it can be trouble. But the posterior elements are typically involved. This is just an example of a femur that's significantly pagetic with the totally disorganized. Look at that. I mean, look how thick the cortices are. Look how you got these areas that look somewhat lytic. This is the kind of situation where if the patient has pain in the bone, alkaline phosphatase is elevated, it's active disease, you always have to try to sort out, is it coming from the bone itself, is it coming from the tight hip joint, or is it coming from something in the back which has nothing to do with anything, but they're having pain radiating down the leg. So you have to be a little bit of a diagnostician. Again, if you saw something like this in somebody with an elevated alk phos, my argument would be that you should treat, whether the patient's symptomatic or not, in the hope that by slowing progression, which is slow but inevitable in many patients, you may do some good, and we'll come back to that at the end. Again, this just shows you what a bowed tibia looks like on the right. And the other thing you notice are these engorged veins. People with skull Pagets will also have very dilated scalp veins, and these engorged veins are a common feature of Pagets in a place where you can appreciate the veins. So the bowing deformity is a problem because the leg is shorter, it's a problem because it looks bad, and it may or may not be associated with discomfort. Many years ago, a woman came to my office in the pre-treatment era. The treatment started being available in the late 70s, but she showed up, she didn't come during the pre-treatment era, she got her diagnosis in the pre-treatment era. She had a nephew who was an orthopedic surgeon. And every year she would go visit her nephew Arthur, who would say, oh, how's your Paget's disease in your tibia? And she would say, oh, I'm having a little trouble, or I'm not having a little trouble. And he would take an X-ray. So she walks into my office in about 1990 with this stack of X-rays. And what's terrific about this, they're not all exactly equivalent in terms of the angles, but you can appreciate that in 1964, the proximal tibia was relatively spared. You could start to see thickening just below that. And the distal tibia also was somewhat spared, but with the passage of time, the bone got bigger, and this is the only disease I know of where the bone actually gets bigger. So if you see somebody with a pagetic bone, it's going to look bigger than the one on the other side, I mean, if it's an extremity. And you can see that the bowing deformity got worse, and actually by the time I saw her, both her knee joint and her ankle joint were a little bit unwieldy. She was having some arthritic type symptoms from this natural progression. Nobody ever treated it until she showed up, and then we tried to treat it. Okay, now this is an example of a fissure fracture where the arrow is pointing out. This is actually very interesting because pagetic extremities, when they break, when the femur or the tibia breaks, it's a transverse fracture. You've heard of those? Transverse fractures. You know, in osteoporosis, we're all terrified that we're going to over-treat somebody with a bisphosphonate and get a transverse fracture of the femur. Well, these fissure fractures occur. Sometimes they're asymptomatic and they don't progress. Sometimes they're very symptomatic. This was a woman who had vague symptoms, and it turned out she had a fracture that was about 2/3 of the way through the bone. We treated her years ago. This was an old X-ray. We treated her with calcitonin. Calcitonin, which today people use as a nasal spray, it's still available as a subcutaneous injection. It's not a very good drug for Paget's. It's not that strong. The original Paget's drugs were calcitonin and didronel. And they both were effective at lowering bone turnover by about half. The newer drugs are much, much, much better. But we gave her calcitonin. There was some concern that with epidemiology, you might make lytic lesions progress. So in a situation like this, calcitonin was the way to go. And this thing healed up. It really did very well, and we didn't have to worry about the thing snapping in two. I had had a patient a couple of years earlier with a similar picture in pagetic bone, and I had actually sent her to have a rod placed, and she had a fat embolus and died post-operatively. I never got over that one, so I tend not to want to operate on these people if I can avoid it. I mean, I suppose if I saw an AFF in an otherwise healthy osteoporotic patient, I would certainly want the surgeons to put a rod in. I think we're in a new era, but having had a patient die following rodding, because I didn't want her to snap the thing in half, but this woman got better with calcitonin. This is something you might see on a board exam. This is what's called a chalk stick fracture. When the fissure fracture or the transverse fracture fully fractures, what you get is what you get if you took a piece of chalk and snapped it in half. So the chalk stick fracture is classic for Paget's, and you can see very thick, disorganized bone above and below. Okay. Now, there are a number of potential neurological complications of Paget's disease when you have involvement of the skull or the spine. Hearing deficit in people with skull Paget's certainly can occur, whether it's sensory neuro or whether it's bony. I mean, you can get ossicle fibrosis from Paget's of the ossicles. You can get sensory neuro abnormalities. It's not entirely clear what all the mechanisms are. There's some evidence that if you are starting to lose hearing because of Paget's in the skull and you treat the Paget's, maybe you can arrest some of the hearing loss. The problem is most people with Paget's are older, and many of them have hearing loss anyway. So whether you can really do much or not, but I think if you had a slightly deaf patient with skull Paget's, I would argue to treat it. Various cranial nerve deficits have been reported because of the thickening of the bone in different places that can impair this. Mottled retinal degeneration and angioid streaks in the retina, I had never seen it, but then I'm not very good at looking at retinas, but it's supposed to be common. I'm not sure what it means. Basilar impression in hydrocephalus, I'll show you a couple of slides. That's rare, and I think it's even rarer today because most people don't have severe skull involvement. The bone softens and the skull sort of starts to sink onto the odontoid process, and you can get blockage of CSF flow, and you get this. If you pick this up, it's not the basilar impression that's the problem, it's the hydrocephalus that can be caused. This is where you would shunt the patient. The patient may present with ataxia, some dementia, some urinary incontinence, and when you do an MRI, you see the dilated ventricles, and it's because of bony obstruction, and what you do is you put a shunt in, and you can really get tremendous recovery. Myelopathies, radicular neuropathies, certainly, spinal stenosis. And then there's this thing called the spinal vascular steal syndrome, which probably exists. I'm not sure we see much of it now, but if you've got somebody with an alk phos that's 1500 and they have extensive spinal involvement, the argument is that the very vascular bone is stealing blood from the neural tissues. And again, if you arrest the pagetic state by giving zoledronic acid, you can make that much better. So this is an example of a pagetic skull. This was an elderly lady in her mid-80s who had developed severe headaches. And clearly she had Paget's disease and had a diagnosis made initially some 40 years earlier, and she had a very high alk phos of about 1,000. Look at that thickening. I mean, it's extraordinary. We treated her with a bisphosphonate. Her numbers became normal. Her headaches persisted. Her neurologist thought that the thick bone was probably tugging on the dura, and that since we couldn't do anything about the bone, we weren't going to easily get rid of the headaches. Now, it's a lesson in humility for the physician who gives the zoledronic acid that it doesn't always make the symptoms better. But what it taught me was that this lady, when she first developed her Pagets of the skull, didn't look like that. It took a long time to get that way. And I would argue that if I saw somebody with skull Pagets and the ALK-Phos and CTX or whatever markers you're using were clearly elevated, I would be very tempted to treat and hope that I could get the patient into biochemical remission, implying that there would be less further slow progression. And maybe every 10 years you give a dose of Zal. I mean, is that so bad? In the hope that this would never happen. Now, one could argue this could still happen and not cause pain. So, like, who cares? But I mean, you have to use judgment. There's no official guidance here. But I think having seen what it can do, if I can easily and relatively inexpensively and with just one day of feeling fluey make a difference in terms of not letting that happen, I think I'd rather do it. This was a woman who had hydrocephalus due to Pagets of the skull, including a lot of changes in the occipital area. It's a very, very old slide. And this, again, you can't really appreciate on these old pieces, but there's a lot of bone around her brainstem and around her cerebellum. And she actually came into the old clinical research center. She had been seen previously, was known to have this Pagets of the skull, but she came in for some study we were doing, and the day after she was admitted, because we could admit people in those days for studies, she had a blown pupil and was comatose. And we, immediately got this imaging, and they immediately tapped her, did a shunt, and she woke up. And so there were things that could really be done. You're not going to see something like this. What you're going to see rarely, you may never see, but you might, is somebody who has symptoms of, dementia, ataxia, urinary incontinence. They've got a funny-looking skull. You do the imaging, you see they have Pagets, and you know what to do. I mean, you're going to give IV zoledronic acid, and you're going to work closely with a neurologist and a neurosurgeon and hopefully make a difference. This was a guy who had been having difficulty with his walking. He had diabetes. There were concerns about all kinds of reasons for this, but what he turned out to have on an old CT was he had Pagets of 3 contiguous vertebrae that couldn't really be seen on an X-ray. Nobody knew anything about his Pagets. The fact that his ALK-Phos was 10 times above normal somehow had gotten not noticed. That wouldn't happen today, but the point is he had Pagets, and this is a vertebra that shows a lot of thickening of the bone and a sort of elliptical looking cord, and our hypothesis was that his cord was being squeezed. I mean, he basically had spinal cord compression. And again, we treated the guy with IV pamidronate, because we didn't have zoledronate then, and he walked out of the hospital. I mean, he got a lot better. So again, if you have these weird neurological cases, there's stuff to do. Hypercalciuria is not unusual in Pagets. We did epidemiology studies years ago suggesting that, it's a little bit of a minor imbalance in resorption formation, so you excrete the calcium that's coming out of bone that may not be going back in immediately. We think that in males with Pagets disease, there's a slightly higher likelihood of renal stones than in males without Pagets disease. I'm not sure that's really true, but that's what our paper says. That's what we found when we collected the data. Hypercalcemia with immobilization is really, really rare. But if you see somebody who has Pagets disease and hypercalcemia, you obviously work up the hypercalcemia. Some of these people will have hyperpara, and if you have coexistent primary hyperpara and Pagets, that may just make the manifestations of the Pagets worse. You don't need a high PTH to get Pagets disease, but if you have a high PTH and you have all these juiced up osteoclasts and osteoblasts, having an elevated PTH is not a good thing. So if you ever found somebody with both Pagets disease, high turnover, and primary hyperpara, that would be a very good reason to take out the adenoma. And I've seen patients whose ALK-Phoses have come well down, not necessarily to normal, after you correct that. So it's a good thing to do. If you have a polyostotic Pagets patient with very high turnover markers, and the patient breaks a leg and winds up, in traction, immobilized, you could theoretically see hypercalcemia, which you would treat with a bisphosphonate. Whether high turnover Pagets can cause primary hyperpara is a very interesting question. It's been raised as that there may be more than just a coincidental linkage, because you may have significant secondary hyperpara with big league Pagets, where the patients are D or calcium deficient, they have significant secondary hyperpara, And maybe in some people, secondary hyperpara evolves into essentially primary or tertiary. So you need to think about that. Gouty diathesis, uric acid can go up a little in Pagets for reasons that I don't think anybody's ever clarified, except that there's a lot of cellular activity and a lot of action. It's about as vague a statement as anybody could possibly make, but you can see an elevated uric acid, and it's been thought, although not proven, that maybe some people are more susceptible to a gouty diathesis. I wouldn't hang my hat on it, but I think it's possible. There are a number of neoplastic complications. I alluded to this a little earlier. Various sarcomas, including osteosarcoma, can occur, and even today with better chemotherapy, very aggressive surgery, these are older people and they don't do well. Metastatic cancer certainly can occur in pagetic bone. I'm the section editor in Up to Date for Paget's Disease, and a wonderful piece was written by a colleague up at Harvard where she said, without a reference, that it didn't seem likely that metastatic cancer would preferentially go to pagetic sites. And I replied that I don't know that it preferentially goes to pagetic sites, but I've got a couple of patients where excruciating new bone pain occurred in a pagetic site that was previously quiescent. And whenever you get excruciating pain, because the pain in Paget's disease is not typically excruciating, it's pain. You know, the hip hurts, the bone hurts. When you have excruciating pain, horrible pain, you got to rule out malignant change or a fracture, obviously. Fracture could cause pretty bad pain. But, you know, if it's been hurting for a while and the patient's still walking around, it's probably not a fracture. It could well be malignant change. And I'll show you a slide of a guy with prostate cancer mets within his pagetic pelvis. Hematologic malignancies, it's been thought that people with Pagets may be a little more likely to get myeloma. I would not hang my hat on that, but it's in the literature, the old literature. Giant cell tumors we talked about before, they're benign giant cell osteoclastomas, and the main reason to care about giant cell tumors is that they're not osteosarcomas, and you don't want to miss the boat and diagnose them. They can get quite big, they can be quite destructive. You want to pick them up early. My favorite story is of a woman who is from an Italian-American family. She had Pagets of the spine, lower spine, part of the pelvis, and her uncle and her aunt both had Paget's disease complicated by giant cell tumors. And one time I was out of the country, she developed severe pain in her back. She saw her GP, they took some Xrays, they brought her and her husband into the office and said, "We have very sad news for you. It appears that you have some kind of metastatic cancer in your back." And she looked at the doctor and said, "Well, could this be a pagetic giant cell tumor?" And that's exactly what it was. And you know, she came in and was biopsied, and that's what it was. So I mean, the point is, you want to exclude it. I have another woman whose mother had died following a big tumor mass in her pagetic skull, which they were calling an osteosarcoma. This was many, many, many years ago. And her daughter eventually developed a giant cell tumor in her spine. And when we first saw the images, which I'll show you, we thought this was likely a sarcoma. Biopsied it and it was giant cell tumor because her mother had had a sarcoma. Anyway, so this was a patient with Pagets who had never been treated, had Pagets of the pelvis, and it looks like the patient had a lot of pain, and it looks like somebody took a bite out of the lower part of the pelvis right there. This was an old CT. This was the non-pagetic side in the pelvis. This is the pagetic side. You see how thick the bone is. And again, you can't appreciate it on the X-ray. If you could see the X-ray better, there's a soft tissue mass. And when you see a soft tissue mass adjacent to pagetic bone, that's bad news. That's trouble. That's what it was. This is the guy who had an old hip replaced, you know, had his broken pagetic hip. It had to be fixed, I think, whatever. But these things turned out to be mets from prostate cancer in pagetic bone. Okay, this was the lady whose mother had had the so-called osteosarcoma, which probably in retrospect was a giant cell, also Italian-American. I've got my name on a paper where they recently did, we had blood on a lot of our patients. We've got a couple of giant cell cases, and they did some genetic analyses. I can't even tell you what they were, but they have defined some of the genes that are involved in giant cell tumors and Paget's disease. I don't understand the paper. So this mass is the tumor, and she was given very high, after it was diagnosed as Paget's, she was given dexamethasone, and symptomatically she got better. This is the iliopsoas. That's the iliopsoas. The mass is much, much smaller. She was subsequently treated with thalidomide, and the thalidomide And again, you won't read this anywhere because it's never been reported, but she was given thalidomide in order to keep this thing from regrowing, because every time it regrew, she had to take dexamethasone in massive doses for 3 weeks, and it got to be difficult. So her oncologist gave her thalidomide, which prevented the thing from regrowing, but he went on sabbatical, and whoever was following her kept her on it, and she got peripheral neuropathy, so it was stopped. But since that time, she's never recurred, and is now probably 15, 20 years, even though she was having periodic regrowth of the thing. The other thing we're doing right now in my other giant cell patient is giving her denosumab. We're giving her Prolia for her giant cell, which seems to be helping her. Now, pagetic giant cells are not the same as non-pagetic giant cells. Non-pagetic giant cells are also osteoclastomas, typically in long bones. In Pagets, the giant cells are typically in the axial skeleton. So there are differences, and obviously a non-pagetic giant cell would be in somebody who doesn't have Paget's disease. So they're different somewhat, but it turns out that a guy in Australia who's an orthopedic surgeon who took care of a lot of non-pagetic giant cells showed that with denosumab you can control these things pretty well. So I've got a pagetic giant cell patient who's on denosumab. I think she gets Prolia, not Xgeva, but Prolia about every 4.5 to 5 months. Her alkaline phosphatase has remained normal on this. I'm not suggesting you use it in Paget's, but I think that's been nice. And in addition, it seems to have helped for a period of time. Recently, she had some new pain and was given dexamethasone again, so it may be that it didn't fully work in her, but for several years, the denosumab seemed to be doing the trick. I would say if you had a pagetic patient with bad kidneys and you felt like you wanted, and you were sure it wasn't renal bone disease, because they can get more than one bone disease, if you were pretty sure it was Paget's causing trouble, you could try denosumab if you can get somebody to pay for it. It's not approved. Well, let me finish it up diagnostically. Bone scans, a way of looking and seeing where it is. So you see on this image, there's a lot of uptake in isolated places, and this was a follow-up after the patient was treated for Paget's, and you don't do follow-up bone scans, but somebody did it, just showing that there was less uptake. You will never see a normal bone scan, but you may see the uptake reduced if you successfully treat. X-rays are still the way to go. This is an example of osteoporosis circumscripta of the skull. Again, a sort of classic thing that they might ask you on a board. This is later stage disease with this sort of cotton, they call it cotton wool, very great thickening of the skull, and you get these sort of cotton wool appearance. This is just showing the huge difference in the architecture of a non-pagetic humerus versus a pagetic humerus with bone overgrowth, thickening, very thick cortices, et cetera. Biochemically, the bone resorption marker that we would recommend would be the serum CTX, fasting, drawn early in the morning. Bone formation, good old serum alkaline phosphatase is what you want. BSAP, in my opinion, is not that helpful because if you've got liver alk-phos, the BSAP may be a little bit elevated. There is some crossover. I started using the P1NP, which I think is a pure osteoblast marker. So really what you need is the serum alkaline phosphatase. You know, initially you might want to do a CTX as well as a P1NP, but when you're following the patient, the good old serum alk-phos will tell you what you need to know. When do you treat? I would argue, and this has been written up a lot, symptoms resulting from Paget's, preparation for elective surgery on a pagetic bone with high turnover. If you have prolonged immobilization in somebody with polyostotic disease, I guess if they got hypercalcemic, I would treat. I don't know that I would do it to prevent it. And finally, the most controversial is prevention of local progression and future complications. Clearly, symptoms will improve if the Paget's is the source of the symptoms most of the time when you treat. But what if you're asymptomatic but you're worried about progression? There's reason to think you might do it, particularly if the Paget's involves long bones, especially weight-bearing bones, where you're worried about progression of curvature of the long bones, vertebrae, where you don't want the bone to continue to get bigger, skull, because you're worried about long-term hearing issues, and areas adjacent to major joints. So the patient presents, you make a diagnosis of Paget's, they feel fine, but the patient is, you know, of an age where 10 years of progression might make a hip joint go out or might mess up the back or might cause hearing loss. The treatment is so simple that it's probably worth thinking about doing it. These are all of the different bisphosphonates. Virtually every one of these has been used in Pagets, but the one you're going to use is zoledronate if you possibly can. Zoledronic acid or zoledronate, this was the clinical trial that compared 2 months of daily, you don't have to write this part down, 2 months of daily recedronate, which was the Paget's dose, 30 milligrams a day for 2 months, versus 1 shot of IV Zol 5 milligrams. At 2 months, something like 63% of the Zol patients had normalized alk phos. By 6 months, it was up to 89% had normalized alk phos. Again, how close it gets to normal is a function of how severe it was. These were not, these were patients with baseline alk phos 3 to 4 times normal. They weren't 100 times, they weren't. But the point is you can get a lot of people into the normal range. And this is just a slide that shows the orange line that even 24 months after that first dose, there were an awful lot of people in remission, whereas the people who got Actonel eventually had to be retreated because they started to go back up again. So the point is that there's a long-term benefit with the IV Zol in people without horrendous Pagets. Before you use a potent bisphosphonate in Pagets, you want to make sure the patient is both calcium and D replete. You can make people hypocalcemic if you give Zol to somebody who's not calcium and D replete. People with Paget should get a little bit of calcium if they're not getting enough from diet, and they should all have normal 25Ds. So you want to know the calcium, the PTH, and the 25D to see what's going on, and also to make sure you keep people replete. This is an example of lamellar bone in L and woven bone in W. This was somebody who'd been treated, and subsequent to treatment, the woven bone seemed to be getting replaced by the lamellar bone. In other words, with lower turnover, the new bone deposition is a more natural lamellar pattern. So this is an argument for why it's reasonable to treat active Pagets that's located where it can be trouble. If you have a little Pagets in the ilium, but the hip joint area, the acetabulum is clean, I'm not sure I'd worry about treating some 80-year-old. But if you've got it in a place where ongoing progression may set up a joint or some other problem, you might want to treat it. So in conclusion, years ago we could treat and get the alk phos down halfway. Today, after very short courses, sometimes 1 dose of Zol every who knows how many years, you can probably normalize indices, and we think that these biochemical remissions are probably a good idea, but we're never going to know. But they make sense. Thank you very much for your attention, and I'm happy to try to take a question, but I want to let you guys get to lunch.